Talk about anxiety next time, and we'll talk about some different subtypes of depression, not just seasonal affective disorder, but some others too. So we'll cover some of these things today, and again, it's kind of a packed outline. I tried to make it as brief as I could, but as usual, I'll try to keep the comments to a minimum, so there's lots of room for questions. But stop me at any time. I don't mind being interrupted. So we'll start off. First of all, I should probably recap a little bit about what is depression. Remember, we did a talk on depression, but we call it clinical depression, or major depression is the other word for it. And remember that major depression it's a cluster of symptoms. We don't have a way other than just talking to someone to figure out, to diagnose it. So no blood tests, no scans, brain scans, or things like that. But it's a cluster of symptoms, usually a down, depressed mood. And also then loss of interest in a lot of things that you used to enjoy, or most things you used to enjoy. These two things occur most often, almost every day, for at least 2 weeks. Usually it's more than 2 weeks. Usually it sort of slowly kicks in and gradually gets worse and worse and worse. And over the course of a couple of months, you or the family member notice that there's something wrong. So in addition to the depressed mood and the lack of interest in things, there can be energy changes, changes in your energy level, changes in sleep patterns. You can also have appetite changes. And when I say changes, I mean either up or down. So those things can be either dramatically increased or decreased. A lot of guilt and worthless feelings. Folks with depression are very pessimistic. Everything looks negative. The world and the relationships, work, everything just is very negative. And unfortunately, a certain number of people will get so depressed that they kind of don't feel so much like life is worth living anymore. It just feels like they'd rather be out of their misery and not have to deal with it anymore. And sometimes that ends up resulting in suicide. So that's really the danger with major depression. Now remember, there's different ways you can get major depression, right? There's major depressive disorder. That's where you get a depressed episode like I just described that interferes with your function, but you don't have any other like bipolar disorder or anything else that's causing it. It's just depression. Then there's bipolar disorder, where you have these mood swings of manic, where you go high in your mood, and then depressed, where you go low in your mood. And there's there's things like schizoaffective disorder. I don't know if anybody ever heard of schizoaffective disorder. I know some people have. It's like a combination, really, of schizophrenia and bipolar disorder. And you can get a depressed episode as part of that, too. So there's multiple ways to get a depressed episode. And then within depression, there are subtypes within depression. So, and that's what we're going to talk about tonight. So you can have subtypes of depression that have sort of unique symptoms that go along with the depression, such as major depression with psychosis. We're going to talk about that tonight. Then you can also have depressed episodes that occur at certain times of the year over and over in sort of a cycle, and that can be like seasonal affective disorder. That's another subtype. And you can also have depression that occurs with some other sort of regular event. So after a mother delivers a baby, for instance, that's called postpartum depression. Or you can have it after, premenstrually, and that's called premenstrual dysphoric disorder. So these are all types of depression. And let's talk now about what makes them different. One of the things I thought I'd do is to describe some of these things. It may make it a little more real if I describe some cases. I've often thought in here it'd be nice if I had a TV screen or some way to show actual cases, of how folks look when they're depressed and when they're not, or when they're manic and when they're not. Because those things are dramatic and pretty easy to see for everybody. The problem with that is, as you know, there's confidentiality, and so. I don't know that that's going to happen. But I'll keep my eyes open. If I happen to see any tapes or anything like that, I'll certainly bring them in, because I think they're very instructive. So I guess the first thing, let's talk about major depression with psychosis. And this first case, we'll describe it. Now, these cases aren't real cases. I mean, they're basically little pieces of real cases is kind of how it is. So don't worry about confidentiality. But for our sake, we'll talk about this first case. It's a middle-aged male, and he's diagnosed with he's diagnosed with cancer, and he becomes clinically depressed. He starts getting into one of these depressive episodes, major depression. Okay, he gets sleep problems. He stops eating and can't concentrate. Feels worthless and guilty. He happens to be a spiritual man, and his faith is one that does not believe in seeking modern medical treatment for illness. So he gets, but he's got a family member that doesn't have the same spiritual belief and convinces him, you got to go see a doctor, you got cancer, you got to get treatment, this is treatable, talks him into it, he goes and gets treatment from the physician, and his cancer actually goes into remission. So the cancer's not even the issue anymore. But his depression continues, okay? And with the lack of sleep, he starts to feel like that he's sinned and that God is punishing him for seeking treatment, and that he's condemned him to death. God has condemned him to death. He's losing dangerous amounts of weight at this point. This gentleman's not eating very much at all. This is an example of major depression with psychosis, okay? Does anybody have any questions about that particular, this cluster of symptoms before we go into more detail? These cases can be kind of difficult because the person usually doesn't realize that they have a problem. They usually, one of the things we should talk about is what is psychosis. We've talked about it a couple times here before. It's kind of a fancy word, and I think maybe sometimes it's a little hard to understand what it is. But basically, in a nutshell, it's just when you're not thinking in reality. So if your mind is, I tell people, the way I put it is, your mind plays tricks on you, okay? But understand that you don't realize it's playing tricks on you. I mean, you don't think it's playing tricks on you. At the time, when you're psychotic, you see certain things and you're convinced that they're there. They look very real to you, just as real as I look standing in front of you now. So there are different types of psychosis. There's hallucinations. Have you heard of hallucinations, everybody? Hallucinations can be any type of sense that you have. So it can be, you could have a visual hallucination, and that's something that you see that other people can't see. You can have an auditory hallucination, which is where you hear something that other people can't hear. And, you can even have olfactory hallucinations, where you're smelling something that nobody else can smell. You can have tactile hallucinations, where you feel like, you've heard of people feeling like bugs are crawling on their skin, but there aren't any. That's a tactile hallucination. So hallucinations are more sensory, I guess. That's the way I put it. Delusions with a D, those are thoughts that something's happening when it isn't. So it's, to give you an example, perhaps the FBI is, somebody becomes convinced that the FBI is bugging their phones and tracing them everywhere they go. And, that's a paranoid delusion, usually. I mean, I suppose the FBI really could be. Now, and interestingly enough, that's kind of the difficult part, is figuring out, is this something that's really going on or not? And a lot of times delusions are things that are fairly believable, and so it's hard for the physician and the family sometimes to realize to know if it's really a psychotic symptom or if it's is reality. One of the ways you can tell is that when somebody gets a psychotic thought, it's on their mind all the time. They cannot get it off. It's like a broken record. So the first thing they think about when they get out of bed in the morning, let's use this gentleman as an example, that he's condemned to die by God. So the first thing he thinks about, and all he thinks about all day long, is this thought. And he's convinced he's going to die. And what's the sense in eating? If you're convinced you're going to die, you don't need to eat, right? And plus he doesn't have an appetite from his depression. So that's one other way to tell if it's psychosis or not, is if it's on the mind all the time like that. That's a little clue or a warning sign that could be psychosis. Now, when somebody gets depressed and then gets psychotic, a lot of times the psychosis will go along with the depressive theme. Okay, so maybe it's it's feeling like you're responsible for a loved one's death, for instance, and that's a delusion. I mean, you didn't cause the loved one to die, but they died, and in your mind you did something to cause it, and that could be a delusion. Being punished for some perceived wrong, like this gentleman in the example I gave. He feels like he's done something wrong and he's being punished for it. Probably he hasn't. I mean, and as you'll see when we talk about what happened at the end, he gets better and that thought gets better. So another one is like the body. Your body is rotting away. That's another one. If you see somebody that has that kind of complaint, you got to wonder about depression, major depression causing that. Being bankrupt is another symptom that can occur with depression that causes psychosis. And the person really has plenty of money. You talk to the spouse or the family, and they have plenty of money, but they are convinced that they're going into bankruptcy. Usually, the way this psychotic depression is treated is you definitely have to use some type of medical treatment. Psychotherapy alone probably isn't going to work, at least in the beginning. Certainly, I would recommend psychotherapy once the psychosis is cleared up some. But when they're psychotic, believe me, I've tried this. You can try to convince them over and over again that what they think is not true, but all they do is they get very angry with you, and they don't want to talk to you anymore. Because it's sort of like me trying to convince you guys that I'm not standing up here right now. There's somebody next to you saying that. What do you mean? Dr. Henley's up there? I don't see anything. I don't know what you're talking about. Eventually, you guys are going to get kind of upset about that because you're going to say, well, he's right there. What are you talking about? So that's sort of the same thing. When somebody's psychotic, it doesn't do a lot of good really to argue with them. But it's better to just, to try to calm them down or distract them away and talk about something different if you can. That's difficult too. So you really need medication or ECT. First, let's talk about medication. Medication would be, medicine for the depression, but you probably also need something for the psychosis, an antipsychotic medicine and an antidepressant medicine. Usually, that's sort of what most doctors would do, is start both of those medicines. If the psychosis is kind of mild and not really interfering with their function so badly, then some doctors would start an antidepressant only and give that some time to work. The other thing is, and so that's okay if the psychosis isn't too bad. But if the psychosis is kind of bad and it's interfering with the person, eating and they're losing a lot of weight and things like that, then you probably need medicine for the psychosis. The other treatment that's very good for this is ECT. It's electroconvulsive therapy. Some people call it shock therapy. I don't really like that because it sounds like we're torturing someone, and we're really not torturing them. But especially in an elderly person, older folks with psychotic depression, older folks are a little bit more frail in general, so they can't afford to lose a bunch of weight, for instance. They're more frail overall, and I think we all know that. But with the medicines, it takes them a while to work. 2 weeks for any benefit at all usually, and then 4 to 6 to 8 weeks for full effect, and sometimes 10 to 12 for the absolute full effect. So that's a long time to wait if somebody's not eating and they're losing a bunch of weight, especially if they're elderly. So ECT sometimes becomes a first line of treatment. In this particular case, after one trial of an antidepressant medication, the patient was not improving, and there wasn't time for another trial because we decided that wasn't. We didn't have the luxury of time. The weight was dropping off really quickly, and we were afraid this gentleman was going to end up in the nursing home or somewhere in the hospital. So he was hospitalized acutely for ECT, and he received 6 to 7 treatments, and the psychotic depression was put into full remission. And in this case, the whole thought of him being condemned to die by God and for sinning by seeking medical treatment, this whole thing went away. And he felt more comfortable about seeking treatment. His depression lifted, and he came back to baseline. The antidepressant medication was started after the ECT and was maintained. It could prevent him from getting depressed and psychotic again. Ideally, if you can prevent the depression, a lot of folks think that then therefore you'll prevent the psychosis too. So you may not need the antipsychotic medicine the whole time if you ended up using that. Any questions about psychotic depression? Anybody ever heard of anybody like that, or having treated a case like that before, or anything? No? Okay. So the next type of depression is seasonal affective disorder. Okay, that one is it's a kind of an interesting disorder, really. It's let me give you a case first, and then we'll talk some more about it. But this one hypothetical case is a middle-aged female with no history of mania or hypomania, so probably no bipolar disorder that we know of, who becomes clinically depressed in the fall every year for the past 5 years. Just in the fall, okay? The episodes lift in the spring every year without treatment, and she's tried antidepressant medicine for the past 2 years, but the episodes seem to be getting worse with the treatment rather than better. So what is this? Okay, seasonal affective disorder is when you get remember the depression symptoms we talked about. If you get those same symptoms and they occur seasonally, and really in the books and stuff, it doesn't say that it has to be in the fall and winter, but mostly that's what it is. But if it occurs in the fall, if it occurs seasonally like that, the depression, and it doesn't occur in the other seasons, so for instance, in this case, the person gets depressed in the fall and winter, but not in the summer. And as long as you haven't had as long as your mood is seasonal like that for at least 2 years, you can make the diagnosis of seasonal affective disorder. Incidentally, seasonal affective disorder, affective means mood, so seasonal mood disorder is what this is. And the reason it says mood is because really you can have bipolar disorder, and a lot of folks that do have bipolar disorder, it is seasonal. What you'll see is these folks get depressed in the fall and winter, and then as the spring comes in, they start to get more hypomanic or manic. So springtime, the psychiatric units are full because folks, they get more manic during that time. Now, I want you to think for a second about this, because how many of you out there, I mean, I'll admit, I'll raise my hand. I mean, in the winter months, what happens? As the fall and the winter, and right now, what are we dealing with? We're dealing with kind of short days. There's not very much daylight. What daylight we have is muted, right? It's cloudy, it's dark. There's some days that I'm at work and it looks like, I look out the window and it looks like it's dark, but it's the middle of the day. All of us, I think, experience some degree of a lower mood during these months. And we've talked in here before about, I think that my theory is that some of these illnesses are really just along a spectrum. We all have moods, obviously. All of our moods fluctuate day to day, and certain things can change our moods, right? Some people end up with a full-blown mood disorder, meaning it interferes with their function. Other people just kind of get down. Doesn't really interfere with their function too much, but they just are more down in the winter months. Now, one of the interesting things I think about this disorder is really when you look at the symptoms of it, they sort of look like hibernation symptoms. What do? We crave sweets. We want to sleep all the time. It's hard to get out of bed, right? In the winter, how easy to get? I don't know. It's hard for me to get up in the winter. So I think it's the same for a lot of us. And I think our bodies have a tendency, and there's some biology behind it. I'll talk about it in a second. But I think our bodies have a tendency to want to withdraw and almost hibernate when it's cold and the days are short and it's so cloudy. So if you take that and you magnify that into a full-blown mood disorder, that's probably what seasonal affective disorder is. Now, the one thing to be aware of or to look for is you want to make sure that there's not some recurring stressor every fall or every whatever season it is that these moods kick in. So if it's somebody who has to go to school every year and they're getting depressed because of school, that's a little hard to sort out, I suppose. So, or if they have a seasonal job and they're unemployed for certain months and they start to get depressed every time they get unemployed, that may not be seasonal. It may be seasonal, but it's probably related. It may be related to the stressor or the job loss or whatever. So you got to keep that in mind too. But interestingly enough, this sort of makes some sense. Is that this disorder is much more common in northern latitudes, right? So you go down to the equator. Not a lot of people have this. Why is that? Well, again, maybe because of the sun, right? Maybe they have a little nicer days than we have up here. So I've had patients actually who have spent winters in Florida and places where it's warm and sunny out, and it sort of takes care of their problem. They don't have so much trouble with the moods anymore. So that's right. Yeah, I need to write a script for everybody goes to a warm climate in the winter months. Indiana would be, or Hagerstown, or the area here would be depleted of people. 60 to 90% of these cases of seasonal affective disorder occur in women. That's not really a huge surprise. I think the 90% is probably a little high. But I think, overall, women have a 2-to-1 incidence of depression over men anyway, twice as much. So, now, a couple things. One is the biology to think about, okay? You know that our bodies kind of our brains have their own clock, and so they do have some regulation. We know that for a fact, that they regulate the brain regulates itself through a day, to the 24-hour day, but it also has a little gland in the brain called the pineal gland. And you guys, have anybody ever heard of melatonin? Melatonin is, you can buy that over the counter and all this. supposed to help with jet lag. I don't know how much. I've tried it. It doesn't seem to help much. But melatonin is actually a hormone in its pineal gland. It secretes melatonin. And when it gets dark, the melatonin goes up and you get sleepy. And then when it gets light, it suppresses the melatonin. So that may be there may be some biology somehow that may be linked with some of this, with well, certainly with our difficulty getting up when it's dark on the winter mornings. Our body has a built-in. Basically, what I'm trying to say is that our body or our brain has a built-in regulator that tells us when we're supposed to be awake and when we're supposed to be asleep. And we're not normally nocturnal creatures, and so when we try to wake up, when we try to work night shifts, let's say, or we try to wake up at 6 o'clock on a cold winter morning, our body's fighting us. It's telling us, hey, you don't need to be doing that. So some people, the other thing I'm trying to get to is that I think some people's brains may be more sensitive to the seasonal changes like that, and so they may end up with full-blown depressive episodes. So back to one last thing about the treatment. I mentioned in this case that the person tried an antidepressant and they got worse. Well, that can definitely happen. It doesn't happen in every case. But some people who have more cyclical depressions, depression that occurs, every 2 years or every year, around the same time or something. Those cyclical depressive folks, when you use an antidepressant, they sometimes don't do as well. They tend to, they may come out of the depression temporarily, but then overall what happens is they end up getting more cycles of moods. So these folks may end up getting more depressed now in the summer. It's starting to bleed over into the summer. So the antidepressant is worth a shot, but it's something to consider that, if you're going to use it, probably what you ought to do, or you ought to have your family member do, is chart their moods so that if they're going to get worse, they're going to see it. Because moods can change kind of subtly, and it's hard to know unless you're really writing it down at the end of every day. The other interesting thing is that, has anybody ever heard of light therapy? I mean, light therapy has been studied and shown to be helpful for folks with seasonal affective disorder. What light therapy is basically it's a light that mimics the sunlight. Doesn't have the harmful UV in it, but it's a broad spectrum light, and it's in a box, And the idea is that you sit in front of this light, and you don't have to just stare at the light. You don't necessarily need to burn your eyes or anything. But you sit there and you read in front of this light for an hour and a half to 2 hours a day, and that sort of I guess it must reset somehow your melatonin or something. It somehow treats the seasonal affective disorder. I remember in residency they were selling, somebody had come up with the invention of a ball cap, like a baseball cap, with a little light in it. So people walk around, and the trouble is the batteries don't last very long, and so, but imagine they spend a fortune on batteries walking around every day for 2 hours with a bright light shining in their face. But that's one way, that's one interesting kind of novel way, for folks, especially for folks who aren't too interested in medication. If you not want to take medication, that's one thing to try. If you are going to take medication, one of the things you'd consider with this is a mood stabilizing medicine. And it's interesting, you might say, well, that's for bipolar disorder, doc. But again, this may be some variant of that. These aren't folks that necessarily get manic or hypomanic every spring, but their mood does improve in the spring. And because they have sort of a cycle of their depression, this mood stabilizing medicine may smooth that out. So it's something to consider. And in this case, the case that I gave you, this person went to see a psychiatrist. And since it was a cyclical depression, like I mentioned, and maybe worsened by antidepressants, a mood stabilizer was chosen. The patient ended up taking the mood stabilizer all year long, but it helped stabilize the moods all through the year. So she didn't have too much depression in the fall and the winter. And the idea there would be to stay. You'd probably want to stay on that, especially if you've had 5 years in a row of having trouble like that. If you go for a year without it, you probably want to stay on that to keep you from having that again. Now that's different for everybody, and it also depends on how well you're tolerating the medicine. If you don't like the medicine, if you're having side effects or something like that, then it might be worth after a year or so coming off of it and seeing how you do. But if you get depressed again, remember what I said a long time ago with depression. You get depressed once, and you get treatment and you get better, probably good to stay on that medicine for at least a year. If you get depressed again, that's the second time, you need to stay on for at least 2 years. If you get depressed 3 times, the chances of you getting depressed again, 90% or more. So probably, I wouldn't take those odds. So I would recommend to the person that they need to stay on medicine from that point on. And it would be the same thing with this, this seasonal affective disorder. So question, anybody ever heard of this disorder before or read about it? I think it gets a lot of press. I think people talk about it a lot, especially here in the northern climate. So any questions? Yeah?
When people do decide to use that light,
yeah.
Do they use it every day at the same time and for the same length of time?
Usually that's the best advice. The question, and I'm going to repeat the question for the camera here, but the question is when you use the light, do you use it for the same period of time, same amount of time, and the same time of day every day? And the answer is yeah, you need to use it every day. It should be, usually it's first thing in the morning, although I've heard people experimenting with nighttime at different times. I'm not really an expert on that, but I would say that to me it makes the most sense to use it at first thing in the morning. You get up, and that sort of helps you get through the darkness of the morning, and you read for an hour and a half, 2 hours in front of that light, or you can eat breakfast in front, whatever you do. It's a little inconvenient because those 2 hours you've got to find something to do in front of that light. But let's say you're somebody who likes to watch some TV, and you don't have to be right at work right away or something like that. You can have it sitting next to you while you're watching TV. So it doesn't have to be direct. It can be indirect light. It just has to get to your retina basically. Does that answer the question?
Yes, but I'm the opposite. I'm a happy morning person, and I'm that way all day. But I know someone who I think is like this.
Okay. And so the question, about the time of day. This is about the time of day, or the question? How do you convince someone to look into this, or that they might need to look into this? That's a good question. I've had that question a lot. So it's basically if you have a loved one that you're concerned has depression, and really this could be any kind of depression, really. It doesn't have to be seasonal, but any kind of mental illness, I suppose, anything that's affecting their brain. Because our society stigmatizes this stuff because they don't understand it, and that's the reason for the talks. Anything we don't understand, we sort of stigmatize, and so people, I think, are kind of scared to admit that they have something like this, or to even consider the idea that there's something going on like that. If it's interfering with their function, my advice is, if you have a loved one, is you start talking about it. You say, hey, Sally or whoever, I just have kind of, I love you. I love you an awful lot. Maybe start with something positive like that. And then go into what you noticed. It seems like lately you just haven't been really in very good spirits. You've been kind of negative about things, and whenever we talk, it seems like you're kind of negative. And I'm not picking on you or anything. I still want to be your friend, or all this, but I wondered if maybe you ought to look into that a little bit. And here, I looked on the internet or went to the library, and I pulled up some stuff on depression. And, it looks to me like you might have all these symptoms. Maybe you ought to go see Dr. So-and-so or something like that. That's kind of how I'd handle it. Now, you're going to get different responses. So some people are going to say, well, that's not a bad idea. I guess it does look sort of like I might have that. And I've noticed that. Some people are going to be very receptive, in other words. And other people are going to say, what? Are you calling me crazy? What's the matter with you? You're going to get all those different kinds of responses. And if they do that, at that point, you're basically done. You have to just say, no, I'm not calling you crazy. I just thought maybe it might help you to see somebody. And then drop it. They may get upset and still rant and rave about it and all that, but just drop it and maybe talk to some other person about it and see if they can approach them so that they get another person's opinion, pastor or somebody else. So the more people that come to them, then they're going to probably start scratching their head thinking, geez, if they notice it, and they notice it, and they notice it, and they notice it, maybe I should get some treatment. So that's the best advice I have for how to approach somebody about, talk to somebody about it. But there's a lot of times where people have to be drug in to see me. You know, I've had people families have to drag them in. You know, they don't want to come in. There's nothing wrong with me, you know, that kind of thing. But the family all knows they're acting differently. So, does that answer that?
It does.
Okay.